All right, good morning. I'm going to discuss upper extremity regional anesthesia. I have a lower extremity regional anesthesia lecture and a truncal, as well as like individual lectures on regional for carotids and regional for breast surgery. So today, regional for the upper extremity. Now, I just want to emphasize you don't want to take it for granted that you can cause a lot of harm. Before you do a nerve block, you really want to understand the harm that can be done so you can prevent it and recognize it, God forbid it happens. So permanent nerve injury, I got a slide on that. Pneumothorax, if your needle tip touches the pleura, you're going to have pneumothorax, right? So the goal is once you go through the skin with your needle, find the needle tip right away and keep it on the screen throughout. And as long as you have your needle tip, your target, and the local anesthesia spread, the ultrasound makes things safer. But if at any point you kind of become blinded by the ultrasound, I don't know if you know what I mean by that, but you're kind of like so intent on looking at the screen and you're not really paying attention to the hand that's driving the needle, you can almost have increased risk when you use ultrasound. So as soon as you get through the skin, aim your probe, rock your probe back towards the needle, find it, and don't advance until you see the needle tip. If you put the needle 2/3 the depth in and then go look for it, you could already be in a structure that's important. Keep in mind that it's going to alter the motor and sensory exam. So one time, I had a surgeon I got along with very well. There was a wrist, I think it was a knife injury, kitchen knife. Wanted to surprise him with a block before he got there, so he could go right in because he's kind of guy who wanted to get moving. And as soon as he got there, he's like, "All right, let me do a quick motor exam." And you can't. So even if you have consent by the resident, the orthopedic resident, you want to make sure that the attending has done their exam or they're comfortable with you putting the block because you're going to disguise that. And then the age-old concern of hiding a compartment syndrome. So compartment syndrome presents with pain, which is kind of out of proportion to the surgery. And so if you had a really dense block, there is the potential that you could hide a compartment syndrome. Small like editorials and things kind of say don't worry about it, but whenever you do nerve block, you really have to respect the surgeon's input. And if they're not comfortable with it, it's off the table. Don't even go for it. So you'll notice it here with certain tibial plateau fractures and things, and just kind of respect what the surgeon's saying there. Total spinal anesthesia means that your needle tip gets intrathecally. Now, there's old cases, reports of this with interscalene block before ultrasound, where the needle angle was too low, they went too far. The nerve root has epinurium on it, and eventually that epinurium fuses with the dura. So if your needle tip gets under the dural cuff and you inject, you can have total spinal, which you could imagine would put you in a world of hurt very quickly. And I was at ASA last week, and a guy told a story of how he was doing a paravertebral and somehow ended up with a total spinal. So you always want to be ready to address that, which would be airway support, epinephrine, and have, be in the right location. If you're doing a block and you have total spinal on the floor, that's going to be a problem, right? So the ones that are higher risk, maybe you don't do there. Inadvertent epidural anesthesia. So if you put a big volume of local and it drifts its way towards the epidural space, you're going to have epidural spread, and that might present with like soft blood pressure. So every once in a while, I'll do a erector spinae plane block, and the next cuff pressure is like 40% lower. So whenever I go up to do these ESPs in the floors and ICUs, I have ephedrine and knee in my pocket because, and I don't just pop the block in and bail. I make sure that the cuff, on the floors, the cuff is cycling every hour. So you want to make sure you change that every 5 minutes or so. But then tell the nurse you can put this back after 20 minutes because you don't want them having every 5-minute blood pressures for the next 2 days, end up with a wrist drop. The phrenic nerve, I got a bunch of slides on it, so I'm going to wait till I get to that. Horner syndrome, right? So anhidrosis, meiosis, and ptosis. I don't know how you look for anhidrosis. It's like no sweating on that side, but ptosis and meiosis are pretty easy to pick up. They kind of present like a corneal abrasion. Like you go into PACU and they're sitting there like this, and you're like, oh, I got a corneal abrasion. But if it's after a shoulder surgery, it's more likely a stellate ganglion block. inadvertently. So the interscalene block has a 5% risk traditionally, probably less now because we use lower volumes now, and with ultrasound put it right where it should be. There's a 1 in 20 chance that you could have this Horner syndrome. So you want to be able to recognize it and reassure the patient. So it's not a complication, it's a side effect, right? There's a little difference there. Like the phrenic nerve gets whacked 100% of the time with an interscalene block. That's not a complication, it's a side effect. So the goal is to not take away the phrenic on someone who won't tolerate that, which I'll talk about. Patient falls, anytime you're doing like lower extremity stuff, especially, if you get femoral nerve spread, the quad's going to weaken. So the second they put weight on that leg for the first time, so you did your block, they go upstairs, they get up to go to the bathroom, they put weight on the leg, boom, it buckles and they have a fall. And there are falls all across the country that continually reoccur, the reoccurring issue. So always warn the patient, even with your adductor canal blocks, say, hey, listen, this is a muscle sparing block. It's less likely for you to have quad weakness, but still there's about a 1 in 20 chance that you could have some quad weakness. And so always walk with assistance or with crutches, or just be cautious. And then obviously we're always ready for local anesthetic systemic toxicity, which is something if you recognize, you can fix. If you don't recognize, it can be fatal. And I have a whole lecture on LAST, which I'll give another time. All right, so I want to discuss this on this kind of like full disclosure warning part of the lecture in the beginning. It's about nerve injury, so what do you tell your patient about the risks of the procedure and all? So basically, very high risk that they can have some persistent numbness. I've heard even up to 1 in 10. This is 1 in 50 it shows here, where you might get a call that there's some persistent, numbness in the distribution that you did your block. And what it means is you probably ding the nerve a little bit and irritated it. It's probably going to get better. At 3 months, that risk gets much lower, maybe 1 in 1,000, 4 in 1,000. But the permanent nerve injury risk is kind of quoted at that 0.05%, which is 3 in 10,000, right? 2 in 10,000, 3 in 10,000. And when you have a 17-year-old wizard of a baseball pitcher, you want to be much less aggressive on that supraclavicular block, or maybe even offer something else, versus an AV fistula who has an EF of 10, who you need that block to really work so they don't die under general anesthesia. Those are two extremes. I'm going to be a little more aggressive on that Benamol patient, that vascular patient, because that block is preventing them from needing an induction of anesthesia and positive pressure ventilation, whatever else. But I'm going to be not aggressive on and not abuse the nerve on someone who has a future in sports. So keep in mind too, when you have an injury, I've never had an injury, thank goodness, but in our group we've had them. And keep in mind that it looks like data-wise, like 7 or 9 out of 10 of them are from the positioning. So picture your shoulder. I did shoulder yesterday, it was lateral. They're in a weight, right? And the weight's pulling for hours. And they're infusing 10, 20, 30 liters while they're doing the arthroscopy. And that's making everything swell and push on the nerves and change things. And, that traction is probably what explains the high risk of permanent phrenic injury in the earlier studies. Like they would say there's like a 1 in 1,000 chance of a phrenic nerve injury. Maybe it's more positioning. So the problem is when you have an injury, you do an EMG and you say, where's the injury? They're not going to be able to differentiate a traction injury from a needle caused injury. And so it's going to be difficult. That's why it's so important for you to document. I saw my needle tip and my target, and there was no needle nerve contact, no pain on injection, patient was awake. Like when you and no twitch at less than 0.5. These are ways for you to say in your record that I was as careful as possible, and to the best of my knowledge, I had no needle nerve contact, and that will help make a little better case that maybe it was positioning injury. By the way, these pictures, so you got the epinurium wrapping the whole nerve, you got the perinurium wrapping the whole fascicle, and then the endonurium is any non-neural element inside the fascicle. So in the fascicle, you have axons and all this like matrix. So this is showing when they took a cadaver, they put a needle intraplexus, and they injected 0.2 of 1 ml of Indian ink. And they were trying to avoid the nerve structures when doing that with ultrasound. So similar to how we may do our supraclavicular nerve block. And what they found is a lot of times there was this extra epineural ink. I guess that would be not very concerning. But frequently it was subepineural. So epineurums are on the whole outside. So it's subepineurial, but it's not through the perineurium, meaning it's not in the fascicle. But 12% of the time, or 22% of the time, there was damage, axonal damage. And so we probably don't want to, this was like a landmark study to say that you shouldn't put your needle intraplexus during a supraclavicular block, which I'll get to. A lot of people still do that and say we've never had a problem and they work great. But, like I said before, if you have a 17-year-old baseball player, you're not going to go intraplexus. And the good news is a lot of these things get better. But we have 1 or 2 cases in our practice where they did not, and they led to a lot of disability. In fact, I know someone who had a femoral nerve palsy after total knee in a different group of ours, but he has no recollection of the block. It was not memorable. And the patient ended up with a 0 out of 5 quad, which is incredibly detrimental to that patient. And this is one great reason why we now do adductor canal. So when you did the block here, if you cause an injury, even if it's 1 in every 3,000 people, that's not a very big number. Anesthesiologists like 1 in 300,000 when we talk about risk. We don't like 1 in 3,000. So if we cause injury here, you have a lot of disability. If I cause injury here, all right, maybe I'll have a numb medial malleolus or something. Dysesthesia maybe, but it's not going to be catastrophic. And so whenever possible, I don't block the femoral nerve. I block the saphenous and the nerve vasus. Sometimes you have to go up here, like in AKA, but a little less worried about nerve injury in that situation, right? All right, so I'm just going to do the bread and butter stuff today. Obviously, on boards, they're going to ask you where you are. So interscalene is really roots, right? That C5-6 root is your interscalene block. It's going to be forming into the superior trunk. It's not quite the superior trunk yet. It's still the C5-6 root. Supraclavicular, we're kind of trunks divisions. I would say more trunks if that was 2 choices on test. Infraclavicular cords and axillary block branches. I like these cadaveric, plasterized images to help you appreciate what you're looking at. So just picture yourself holding the probe here, right, doing your interscalene block, and you see a round muscle. That's the anterior scalene. You see the 3 stoplights. That's in here in the superior trunk. The 3 stoplights is in the superior trunk. I got a better picture of that in a minute. Behind it, posteriorly, is the middle scalene. And the middle scalene has 2 nerves running in it, the dorsal scapular and the long thoracic. So you have to be careful as you go through the middle scalene muscle that you don't hit any hypoechoic structures that could be that nerve. Because if you get a dorsal scapular injury, you have medial thoracic, medial scapular pain, or long thoracic, you have a wing scapula. Both these are pretty common in the closed flames analysis, especially if you go through with a TUI, which is like a harpoon. I want you to notice the phrenic nerve along the anterior portion of the anterior scalene muscle, but know that even when you inject muscle back here, it's going to spread there. So just consider that it's going to get whacked. And this is cervical plexus. The ansa cervicalis comes out and it gives off greater auriculus, occipital, anterior cervical, supraclavicular, all that stuff. So get appreciation of the anatomy there. All right, so just to run through it quickly. So 5 and 6 come together for the superior trunk. 7 middle, 8 T1 inferior. They each give posterior division, form posterior cord, and that's axillary radial. The hold your arm like this, right? So the medial cord is going to be the ulnar. So if you ever can't remember on the test, the medial side of my arm is going to be the ulnar. The lateral is the musculocutaneous, which helps you remember that it gives off the lateral antebrachial, and then the lateral medial comes together to form the median. And some key nerves that come off of there, I'll show you in a second actually. Just again, a global picture to give you an idea. So our interscalene blocks up here. The orange here is the way they color the muscle, by the way. But couple important nerves. The dorsal scapular nerve, that's the one that runs through the middle scalene muscle. The suprascapular nerve is the major shoulder nerve. I think in medical school we're kind of like made to believe it's all axillary, and that is the motor. But and the shoulder is 4 nerves: it's subscapularis, it's lateral pectoral, but really the suprascapular and the axillary, those are the main ones. And then the medial lateral pectoral nerves, those are the ones we see in our PEX 2 block going between the pec major and minor. And remember, the lateral pectoral is also shoulder. Long thoracic. So the serratus anterior muscle sits on the first 8 ribs and it attaches to the scapula and helps you do this motion. That's the long thoracic. So those are some of the key ones that we go after. I think this is just low-hanging fruit for your boards. I think we all have a good appreciation of like ulnar, radial, median. But what they like to ask is the lateral antebrachial. That comes off the musculocutaneous. So musculocutaneous is the primary supinator. We always think of the biceps as like doing this motion, but supination is really biceps' primary goal. And it gives off the lateral antebrachial. And then the medial side is the medial cutaneous nerve, comes off the medial cord. So that's covered with a brachial plexus block, but could be missed in other situations. Like, for example, if you did a forearm block, you did radial, ulnar, median, you'd also have to do some subcutaneous injections to get those medial cutaneous and lateral antebrachial. So again, key players, you should just really be able to look at each name and say, how is this relevant to my blocks? So the phrenic, we're going to go over in depth. Supraclavicular, we're going to go in depth. We kind of talked about everything else on here. So those are the nerves, but then you could break it down into dermatomes and osteotomes. So this is the dermatomes, right? And so you got a picture. If you make an incision, what nerve do you need to cover in that area? And supraclavicular above the clavicle, right? Suprascapular above the scapula. I always mix those up in my head, but just think to myself for 1 second. Supraclavicular is above the clavicle. So that is coming off of the cervical plexus and it's getting here. So that is not the brachial plexus. So if you're doing clavicle surgery, you could do like a clavicle pectoral block. Maybe I'll get time to talk about that. You could do, the medial 2/3 versus the lateral third. So the lateral third is the brachial plexus. The medial 2/3 is going to be the supraclavicular block, and possibly some osteotomes from T2. And again, the suprascapular, remember I said it's like the major shoulder player, but not for the skin. It's the major shoulder player for the bone. So when the surgeon drives a screw into the bone, that's what hurts. Cutting the skin is like, hurts a little bit. But driving anytime you're putting screws in bone, you want to cover that, and that's a lot of the suprascapular. And then we have, so this is the osteotomes, right? So look, suprascapular, bigger piece, and axillary, and there is a little branch of the lateral pectoral here in the subscapularis, all covered by the brachial plexus. So we don't want vascular punctures because you could get human tomato there, right? So if you're on Plavix or whatever, like I'm comfortable doing the block if I am careful. If you're not super facile, don't do blocks on Plavix, because if you get a vascular puncture, you're going to have a problem. But like for me, I'll just make a risk-benefit decision in that case. Does this patient need the block? Yes, they need it. I'll go for it carefully. If I wasn't good at it, I wouldn't do it. So don't just grab a needle and say, oh, well, Markley does it on Plavix, I'm doing Plavix. Maybe, in certain situations, right? Or call me. But anyway, we got this thyrocervical trunk, and it sends the transverse cervical artery through the plexus. So before you do your block, whether it's supra or interscalene, just throw the color on and look for a pulse stop. Look for the artery. A lot of times the root or the trunk can look like a vessel, or I'm sorry, the vessel could look like a root. So just put your color on real quick. If there's no pulsatile flow, you can bring your needle through that plane. But the transverse cervical corkscrews through the supraclavicular plexus there. And the dorsal scapular comes right off of the subclavian. And remember this isn't part of the upper extremity block, but the thoracoacromial artery gives off the pectoral branch, and that's what helps you find the medial lateral pectoral nerve. And the thoracodorsal goes through the serratus and lat, and that helps you find the serratus plane block. So the arteries can be helpful for you to find the right plane. All right, so interscalene is for two things: the shoulder and the proximal humerus, and that's it. And that's because it only gets the superior trunk, it only gets C5-6, so it's going to be ulnar sparing. So it's not good for the elbow, the wrist, or the forearm. The super, infra, and ax and forearm blocks are everything distal. It's known as the spinal of the arm, except for the intercostal brachial, posterior branch T2. And remember that 3 out of 10 times you'll get the phrenic. I always was told that the infraclavicular cannot get the phrenic, but at the SA this week, they mentioned that 12% of people with 30 mLs infraclavicular can even get the phrenic. So if you've got someone who cannot get a phrenic, axillary is a sure thing, or a lower volume infraclavicular, or an isolated, axillary block and suprascapular block. So I just want to break down the interscalene because this is probably something you'll come in contact with the most. So here's the anatomy. This is the sternocleidomastoid muscle. It's wrapped in the investing fascia, that's the brown. That connects to the trap. Then you have this brown fascia here called the prevertebral fascia or paravertebral fascia. And that kind of wraps around everything. Then you have the third deep cervical fascia called the carotid sheath, which wraps around the IJ, the carotid, and the vagus. Of note, a stellate ganglion block is you put local right there, and you'll get a stellate ganglion block. This is used now for PTSD patients. You'll see this at all the VAs. They'll be doing every couple of weeks stellate ganglion block, and it will wipe out a lot of their anxiety symptoms. And it's really making a difference. We used to do it on the T1 body, and it was complicated, and now it's super simple. You just put the local here. So we have the anterior scalene, the middle scalene, the vagus is on top. So our needle is going to come through the middle scalene, right? So you're going to come through the skin, you're going to enter the scalene muscle, and then you're going to leave the scalene muscle, and you're going to inject. You're not going to go intraplexus. You just have to leave the scalene muscle. So that's the pop you're feeling. It's not necessarily a pop into a sheath or anything. It's that you're leaving the muscle. If you inject in the muscle, it's not going to work. If you inject through the sheath, you want to see the plexus push away from you. So as you inject, the plexus is floating away. If anything expands, stop. And that's why you tell your injector person to give 1 ml. Say, give 1 ml with your thumb. You don't want to give the old heave-ho or 2 thumbs. You want nice low pressure. Because less than 15 psi means you're not intrafascicular, which is a safety check. So you give 1 ml. Patient winces, stop. Get less aggressive. If you start with 5 mLs, before you know it, you got that sub-perineural injection that we pointed out. So just 1 ml, they don't wince. You see the plexus float away. That's the sweet spot. Fill that space up with 10 to 20 mLs. This isn't a workshop, but just to kind of show you, you want to take your probe against the clavicle, sitting against clavicle. Then you aim up in the chest and come off 30. Now we'll give you this bottom view. The subclavian arteries go into the arm like this. So if my probe's against the clavicle, I don't have a cross section through the artery. That's why you come off 30. So you want to get the artery to be a circle. If the artery is a circle, then the plexus is in cross section. Then the nerves go to the neck like this. So here my probe is vertical, but as I scan up the neck, I want what they call paintbrush, where the probe becomes flat, so I can stay in cross section as it enters the vertebral foramen eventually. So against the clavicle, aim up in the chest because the artery is coming up and over the first rib. Come off 30. Get this bottom view. The plexus is described as a bundle of grapes there. Those are the trunk's divisions. Then sweep up following the superior trunk until you get a traffic light appearance. And here is on the upper right here is what you're actually seeing. I always thought it was C5, 6, and 7. It's not. It's C5 and then a split C6. You can see that here in this dissection. This, if you follow it down, will then become the superior trunk, and then it will look like grapes again. So you go traffic light there. So that traffic light grape interface, that's where you want to block it, right when it becomes traffic light, for an interscalene. For a superior trunk block, I'll discuss that in a minute. And then for an isolated suprascapular block, we'll discuss that after. This is the course of the phrenic nerve across the anterior scalene, and it shows you in the picture where it is. This upper left picture is 10 mLs of gadolinium in a cadaver, and you can see that they injected here, but it went everywhere. So just consider that your phrenic will be blocked. Why is that important? 75% of your tidal volume is from your phrenics. There's no crossover from the left to right hemidiaphragm with one phrenic to the other. So that means that each phrenic is about 35% of your tidal volume, which all of you will tolerate. But if you're already failing, you're using your accessory muscles to breathe already, taking away 35% will make you very dyspneic and could lead to an admission or worse. So when you look at your patient, if they're using their accessory muscles, they are not a candidate for a phrenic block. So you'd have to do a phrenic sparing technique. They're no-brainers, but there's some people who have a very reduced expiratory reserve volume because of obesity. I'm talking like that real bowling ball type bellies. You know, if the weight's down here, they're probably going to tolerate that. But if their ERV is shrunk from their belly pushing them up, and then you take away 35% more, they're going to have more shunt because their closing capacity is now in their expiratory reserve volume. It's now in their tidal volume. Your closing capacity, where you have dynamic airway compression, should only occur in your ERV. But as your ERV shrinks, you get dynamic airway compression in the tidal volume. And now you have a sat that's low while you're sitting there. So that's a judgment call. Maybe you'll do more of a superior trunk block. Maybe you use a little lower volume. Maybe you'll warn the patient. Whenever I do this block, I tell them, tonight, the best place for you to sleep is in your recliner. They have a recliner at home and they sleep in there, because what decreases ERV? Obesity, pregnancy, age, supine position. So if you sit them up and they sleep in the chair, they're going to breathe better. And I don't leave them laying flat when I leave the block room. I sit them up real tall, maybe give them 2 liters, and I'll tell them, you may feel a little breathless, but your oxygen's perfect. Look, it's 100%. It's just the function of the block. And if you're ever worried about a pneumo, which you shouldn't be, but you put your probe on there and you see the pleura sliding, you know you don't have a pneumo there. That's a quick rule out. Take the ultrasound, put it on, the pleura sliding, means there's no pneumothorax in that spot. Doesn't mean there's not one here, but where you're looking, there's no pneumothorax. So again, up to 40% of your FEV1, 40% of your FVC, and that's fine if you have reserve. If you don't have reserve, that's not fine. All right, so then there's this superior trunk block. So if you have someone you're worried about a little bit, you might do superior trunk block, which is you just block it a little more distally, but 5% of them are still going to get the phrenic. And to that 5%, it's 100%. So if you can't have a phrenic, you still can't do this. But if you're trying to minimize it, you can do this. And what it basically is you follow the C5 and 6 until you see the superior trunk. And then you keep following the superior trunk until this upper lateral most circle comes off the plexus. That's the suprascapular nerve. If you block distal to that, it's not going to cover your shoulder. So you want to block it right before it comes off. That's what this is about. Say it's around the level of the omohyoid, which swoops down. This is of historical purpose only. I would never, ever, ever do this again. But Seb can attest, we didn't have ultrasound even when I was a resident. We did not have an ultrasound my first year residency. So we used to have the patient lift their head off the bed, and that would bring out the sternocleidomastoid. And we put our fingers on the edge at the level of C6, which is the cricothyroid. We'd walk off into the interscalene groove, and we would bring that out by having them sniff, which pulls up your first rib. That's what the sniffing does, which is the scalene muscles. You can all do it on yourself. Level C6, sternocleidomastoid, walk off, push hard, you'll feel it in your shoulder. We would then take the needle 60 degrees in this parasagittal plane towards the spinous process of T1, get a twitch, lower the twitch till it went away, make sure it was like 0.4-ish, and then inject. but seeing is believing nowadays. All right, supra. So the big debate is, do you go intraplexus or not? So that view I described before in the beginning, that's your supraclavicular view. You're going to see the artery and then the three trunks. I like to scan up and watch where they split so I can see where that divider, that plane is between the supra and middle trunk. This is the Duke slides. This is a Duke slide. Ooh, maybe. Duke, Jeff Gatson, and there was another speaker at the ASA last week who they're very big on not going intraplexus. So they put 2 injections. They bring the needle to the corner pocket and they inject and they lift it up. And then they bring the needle to this upper blue arrow and they inject the rest. And they engulf the outside of the trunks. Other people, other speakers I have heard, will get that corner pocket and then maybe trying the plane between the superior and middle trunk and open that up. Again, if you go intraplexus, there's a 24% chance that you could be subperineal, potentially causing axonal damage. So there's no chance I'm doing this on, I've had to do supraclaviculars on my colleagues. I'm not going to be going intraplexus on them because I got to see them at work every day. But if I have someone who is a cardiac cripple, EF of 10, and I need this case to keep them alive in critical AS, I'm going to get a little more aggressive. But I'm going to use a twitch monitor, and I'm going to have them wide awake. So I have no twitch at 0.6. That's a high number. No twitch at 0.6, and I give that first CC, and they don't grimace, and they're wide awake. I'm going to feel comfortable opening that plane versus someone who is snowed, and you don't have a twitch monitor. You might blow it open. And the plexus is like a spider web. You don't want to blow it open. Remember how the dorsoscapular comes off and the long thoracic and medial lateral pectoral nerve? You don't want to blow all that open and stretch it out. All right, so here's the routine for my supraclaviculars. I will bring the head of the bed up 30 degrees to help the veins sit down. I'll pull down on the arm and bring the chin up. That opens up this space so you have a big area to work. I'll come in the room all the time when people are struggling and patients like this, and there's nowhere to work. A lot of that is inadequate sedation. So you want to give them midazolam, 50 of fentanyl, until they're chilling. If they're apprehensive, especially when you go in with the needle, they're going to do this even more. But I want them to be moderate sedation, not deep sedation. So open your eyes, they open their eyes, they can talk to me. So I'll usually give 1 in 50. I'll look at them. If they're still looking around, I'll give a second 1. Sometimes I'll give a second 50, not always. Sometimes I'll give a third Versed or a fourth if they're still looking around and anxious. But again, I want them to be moderate sedation. Remember when you pull the arm down for shoulder surgery, they have a bad shoulder too. A lot of times I do that and I'm like, here for shoulder surgery. So shoulder down, chin up, head up 30 degrees. You want to stand posterior lateral to them so you have room to needle. And you want to be always direct line of sight to your ultrasound. You never, no matter what you're doing, starting an IV, you never want to be doing this to the ultrasound. The ultrasound's back here. It's always direct line of sight. And I bring the bed up until I feel my pelvis do that. So if you're like this, it's all straining here, and you're going to start to rush, and you're going to injure yourself. So you bring the bed up until you feel pelvis straighten out, and that's the bed height. That should be like your first step for all of your blocks. All right, so I like to compare the ultrasound to the gross section, and this is what the bone looks like. And you can see how the plexus is really like 3 trunks. There's the artery going right through the middle too. And, corner pocket and then upper, that would be the Duke way. Or you could lift it up and then maybe open up the space between the two. That would be your benefit. This is a histologic sections of what these trunks actually look like. Right, so big trunk, trunk, trunk. Sitting on the first rib, subclavian artery, the anterior middle scalene insert on the first rib, and the artery and the plexus come through there. So your needle's coming down this way. Because the prevertebral fascia is so permeable, it will spread its way back up to the phrenic 3 out of 10 times. There is a topography too, like if you think about like the lower trunk and what it's going to become, you can kind of decide in your mind what's really important for the surgery you're doing too. All right, infra. So we got the interscalene for the proximal, humerus, and shoulder. We'll have the supra, infra, and ax for everything below. So this is the infra. What I like about the infra is there's just 3 chords. You know, like for the axillary, there's 4 branches. And for the supra is pretty much a home run, actually. But again, the trunks are a little bit spread out, but the 3 chords are very definitive here. So you have the clavicle, you have the coracoid process, your probe is here. It's a little bit of a deeper block. So in an athletic male, I don't love doing it. It's like really deep, but sometimes you'll see a thin upper chest. Now, why would I do it? Sometimes patients come in and they have like a permacath, like right here, like a big catheter, or skin infection, or something where I can't go my supra. I like supra the best. There's no question the infra is best for catheters. The catheter, you tape it right here, and it's gonna not move anywhere. Up here, every time I move my neck, the catheter is gonna migrate. We've had so many failed supraclavicular catheters. Infra is way better. And then to be phrenic sparing, although now I have to worry about that 13% risk with 30 mLs, but probably it's less with 20 mLs. So basically we have the lateral posterior medial cord, pec major, minor, and you come to the 6 o'clock position and you put 30 mL straight, pretty much. But I'll put 20 there, and then on my way out, I'll get the lateral cord. And the reason is there's like a membrane around it. I also wanted to show you how these are potential spaces. Like in your body right now, there's no gap between the cords and the artery. They're like laying on each other. They were formed that way. You're going to open that up. So that's why you hydrodissect. You don't just like put your needle to your target area and inject. You start to inject before you get to your target area to start to open that plane up. And as that plane opens, you can very confidently put your needle further into that hydrodissection, and you're not like going to rip apart anything. And if you bring the arm out, the clavicle will move. So right now my clavicle is here, but if I bring my arm out, the clavicle goes here. Remember, I'm working in here. So it's probably best to deduct the arms. Oh, there's something called a raptor block now too, which is the same thing, except the needle goes in above the clavicle and it comes out below the clavicle. And you don't see it while it's going under the clavicle. So most chickens like me are not going to be doing the raptor block. It just gives you a better angle. They showed some slides at the ASA this week that you potentially could go the suprascapular nerve is right there. And so they were kind of like antsy about it too. So I wouldn't recommend doing this. I just want to let you know there's something out there called the raptor block, which is a infraclavicular where you go under the clavicle from above. This is pointing out that there's a fascial sheath around the lateral cord. So sometimes it's best to come in and do the 6 o'clock injection and then just give a few cc's on the way out to make sure you get that lateral cord. But the medial cord will get covered because it's going to spread like a horseshoe around. Another look at it after injection. And so what are we missing with this is the intercostal brachial. So T2, every thoracic intercostal nerve comes out, and then it gives a lateral branch. And that has an anterior posterior cutaneous branch. T2, T3, T4, T5, T6. That's what we block with a PEX block. We have breast surgery, we want to do a PEX2 block. You get the lateral branch, kind of transect it, and that gets the anterior posterior cutaneous branches. Well, T2, the posterior branch of that, the lateral branch gives the anterior, the posterior branch of T2 is the armpit. And so that is not C5 to T1, right? So that will not be covered with the brachial plexus. So we have to go after that with an intercostal brachial block, which I have a slide on later. All right, so the axillary block. I think one of the key points that some of the lecturers say is make sure you're not down here. You want to be really up in the armpit there. And there are several case reports where people injected and there was last. And when they lifted up the probe, they realized they were in the vein. So when you're pushing down, you're going to compress the veins. So right before you go in with the needle, lift up with your probe a little bit and say, where are the veins? So you don't want to hit them, especially in the dialysis patients who are having any kind of revision. The huge, huge veins in this area. So the anatomy here is branches, terminal branches. So radial, ulnar, median, and musculocutaneous. So you get, this is the conjoint tendon. And if you put the local here, the conjoint tendon allows it to spread to all three of those. So those get done. But this is a separate injection. So this is, for me, a no-brainer to have the twitch monitor. I will find the coracobrachialis and I'll see a twitch like this and I'll know that it is. But it's very triangular shaped. It has a very classic appearance. But predominantly, whenever the axillary fails, it's because you miss the musculocutaneous typically. All right, probe is too low. They want it more here. You want to be direct line of sight. And this is that conjoint tendon I was telling you about. You're putting the local posterior to it, and that's axillary block. All right, intercostal brachial. So it's funny how they showed on T1 there. It's T2 though. Oh wait, is it 2? No, that is 2. Got a weird angle. So luckily, when we do a PEX 2 block, we get the armpit. So that's a little bonus because breast surgery, they get an axillary node, and it's nice that we get the armpit with that PEX block. All right, so there's 4, me and Brian were talking about yesterday, it was like 4 ways to get this. You could do a skin wheel from the pec to the lat, right? This is your lat, this is your pec, so a skin wheel. It's gonna get it like half the time. You could take the ultrasound and come up over the artery and put in this plane here. And after you do it, you'll see the hypoechoic nerves floating. And that's pretty good. I've been doing that. That's the way I've been doing it. Me and Brian were talking about yesterday how you could just put the rib on T2 and get it there, almost like a higher PEX block. Probably sub-serratus. You know, there's no PEX minor serratus plane there. You just go probably sub-serratus on the second rib and put 10 mLs, and that would get it probably, Brian was saying, more proximally, which will get more coverage. All right, so that's pretty much it on that. Now, there are times when you will need to get the intermediate cervical plexus. So in the old days, so the cervical plexus is this. Intercervical, it's like less auricular, lesser occipital, and the supraclavicular. So if you want to get all them, when would you want to get them? Clavicle surgery, maybe parathyroid or something. Carotid, this is the carotid block. This is the carotid block. Maybe you're going to be putting a cordis in an awake patient. You just put 10 mLs under the sternocleidomastoid, and now that whole area is numb. And Brian, we're talking yesterday, awake before a kidney transplant, the recipient, while you're waiting for the organ to come, sometimes you put an awake line and you can just do that block real quick. So basically, you put the probe on and you find what they call the bird's beak. This is so easy to see because everyone can see their sternocleidomastoid. So when the probe is on there, you can see the sternocleidomastoid form this bird's beak. So this is the investing fascia around this thing. And that investing fascia goes this way, and it joins the trapezius muscle. You're going to pop your needle in, and it's going to feel like a dural puncture, like a flavum. You're going to be like you're putting a needle through tin foil. You're going to pop in there, and then you're going to open this space up with 10 mLs, 10 to 20 mLs. And that's it. That's your carotid block. You're done for your carotid surgery. It's probably one of the easiest blocks there is. So probe on. A regular 25 gauge needle, you don't even need like a stimuplex or anything. And you'll see the local kind of spread down here. I don't really chase the needle down here, just kind of fill this up. So that's called the intermediate cervical plexus block. That's to be compared with the old-fashioned superficial cervical plexus block, which was you just run a line of local up the lateral corner of the sternocleidomastoid. So you hub your needle, inject on the way out, hub your needle, inject on the way out. That's superficial. This is intermediate. And then there's deep, which is not done anymore. where you bring your needle all the way to the bone. See, in the old days, they used to say if you want to do head and neck surgery, you need to get the strap muscles paralyzed, and they would do the deep block. But you would have vertebral injections, you'd have total spinals. It's just something we don't want to mess with when we have a better option. Now, I'll be honest, I'll put the 10 mLs here, and then often I'll run a line of local up and down just to make sure I got it. But this should be enough. So for your carotid, you get in. I already had, patient's going to be awake. I already have the bed turned. I have a wrist restraint on the operative arm. There's some cases where awake patients reach their hand up into the surgical field. So I have a wrist restraint on the operative side arm. The left arm's out, so I can put my A-line and have good AC access. So, but the bed's already turned when you come in the room. That's one less thing for you to do. Like if the bed's not turned, you got to put them on the bed and then turn the bed. Just have the bed turned. You're going to do an awake carotid. Start your Prosthedex, Remy. Maybe someone's doing a line, the other person does the block, and you can be ready in 5 minutes. All right, but again, this is going to get the supraclavicular, which is going to be important for a lot of orthopedic surgeries. Just to reiterate about the clavicle, the distal third is brachial plexus. This is joint, right? Like the clavicle, the glenohumeral joint. This it's going to be a lot of plexus innervation. The subscapularis, the lateral pectoral, the axillary, and the suprascapular. But the medial 2/3 is going to be this nerve, the supraclavicular, and possibly some osteotomes. There is something called the clavicle-pectoral block, where you just put your needle on the clavicle and you lift the fascia up off it, and that's like surgical anesthesia for the clavicle surgery. So that's a real easy, almost like, what was that block called when you put it right at the fracture site? Like in the ER, the orthopedic resident would put the needle right between the fracture and inject, and that would give good anesthesia. So this is kind of similar in the fact that you're right on the bone. You're not really going after a particular nerve. And so maybe you have a trauma patient who has a clavicle fracture and you want to do an ESP and you got to roll them. Maybe you'll just put 10 mLs there first. And that way when you roll them and get to their back, they'll have less pain. Just some of those places the intermediate cervical plexus block can work in ER. This is like a little ER editorial where they use it. All right, so injuries. Having 40% of all claims, right? It's an ASA claims database. Brachial plexus, 38% of claims. So that should get your attention. Now, as we've gone to ultrasound, and patients awake and they have no twitch and they're not in pain, you can lower that risk. But in general, this should really get your attention. So 38% are brachial plexus block. I'm sorry, brachial plexus injury. But remember, 70 to 90% might be from surgical positioning. So that's got to be teased out. But these are the concepts that I was kind of pointing to before. But I wanted to point out that in the middle scalene, there's 2 nerves. So as you're coming through, my recommendation to you, which is not from me, it's from Admir Hadzik, who's like, you know, NY Sora developer, is to use a twitch monitor on all the blocks. Why not? Why would you not want more information? Why would you not want to show in your record to the jury of your peers one day that you did everything you can to be safe as possible? So I use a twitch monitor. It takes like 2 extra seconds, helps give me peace of mind. And then I can tell myself if there's ever an injury that I did everything I could. So you put the twitch monitor on. As you're coming through the middle scalene muscle, if you see the shoulder jumping, that might be a sign that you're touching the long thoracic. And you just try to avoid these hyperechoic areas as you're coming through, especially with catheter techniques. So there's 2 ones for your boards. The dorsal scapular nerve runs down the medial scapular border. So you're going to have this ill-defined medial scapular pain. And then some subtle muscle dysfunction. Versus the long thoracic, you're not going to miss. That's the wing scapula. And I know someone who had this on a medical malpractice attorney. He was the patient. So it was a catheter technique, but it was also a shoulder where the guy was in traction for 4 hours during the case. So who did it? I don't know. But that case never went to a suit or trial or settlement because the surgeon had such an incredible relationship with the patient. And he just said, this can happen and it will probably get better. And it got better. But this is when that happened is when I got really serious about watching out for that nerve as I go through the middle scaling. One of my colleagues' patients. Thank God everything went well. All right. So phrenic sparing block, and this is the end here. So a patient you can't get the phrenic, you go after the suprascapular in a couple ways. You can do it above the clavicle, but that's going to have a little risk of getting the phrenic. But this is the one that I'd recommend. It's called the supraglenoid notch approach. So it's a suprascapular nerve block at the supraglenoid notch. So you put the probe on like this. So you feel the spine of the scapula, you feel a little notch there, you get lateral, that's going to be it. They kind of make a point to aim in a little bit with your probe. And you don't go in the notch. This is the supraspinatus muscle that does this. So you just bring your needle down and you touch the bone right outside the notch and you put your 10 mLs and it will flow into that area. So this is not the suprascapular notch, which was the way this used to be taught. It used to be taught to go through the suprascapular ligament into the suprascapular notch. The problem with that is the suprascapular notch is right in front of the lung, on the chest wall side. So this is the supraglenoid notch. So needle comes in, inject 10 mLs, and you get the nerve proximal. Actually distal. So it's coming from the neck, and it's going to get the shoulder. This is the needle touching the bone and injecting. So the supraglenoid notch. Anyone ever heard of that? So that's the latest and greatest for suprascapular nerve. You got the superior trunk block, isolated suprascapular block, supraglenoid approach, and then the old-fashioned one. So that's majority, but you combine it with an axillary nerve block, which is the probe is right here. And there's this triangular space that has a vessel and it has a nerve in it. And you would bring the needle right here between the delt and the teres minor, and you'd open that space up. So this would be equivalent to an interscalene block for pain. If you would rather, you could do a suprascapular and an infraclavicular. All right, so just to summarize your options for phrenic sparing shoulder surgery blocks. It's a suprascapular and axillary, or a suprascapular and infraclavicular. Any questions? All right, thanks, guys.